Good afternoon and welcome to today's webinar, Building Connectedness, Suicide Prevention in Nevada. My name is Rima Naik and I'm the Performance Improvement Program Manager at Nevada Primary Care Association. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to community health centers and partners to improve access to health care for all, especially for underserved and uninsured populations. For more information, visit us at nvpca.org. This training is a partnership between Nevada Primary Care Association and the Office of Suicide Prevention, Department of Health and Human Services. I just wanted to take a moment to thank them for helping us coordinate this session. Before we get started, I would like to go over a few housekeeping items. During the presentation, please make sure to mute your phone or computer so that we don't have feedback or background noise. Also, please be sure not to put your phone on hold or we will hear your hold music. You'll have the opportunity to submit your questions to today's presenter by typing your questions into the chat panel. You may send in your questions at any time during the presentation. Questions will be collected and addressed during the Q&A session at the end of the speaker presentation. We will also have a 5-minute break during the middle of the session. Today's session will be recorded and slides will be available to participants. I would now like to introduce Suicide Prevention Coordinator, Misty Vaughn Allen. Misty Vaughn Allen is a Suicide Prevention Coordinator with the Nevada Office of Suicide Prevention. Ms. Allen is currently exploring avenues to support implementation of Crisis Now and the Zero Suicide Initiative in communities across Nevada. Ms. Allen also works closely with diverse entities, communities, and schools to develop comprehensive strategies to address suicide. As a Suicide Prevention Coordinator, she facilitates the development of Nevada's Suicide Prevention Plan consistent with National Strategy for Suicide Prevention. Improving connectedness among individuals and across systems increases the possibility of helping and therefore hope. Thank you, Misty, and thank you everyone for attending today's webinar. If you have any further questions, please contact me at rnaik@nvpca.org. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of Nevada Primary Care Association, thank you for joining us today and have a great rest of your day. Misty, I will give it to you.
Thank you so much, Rima, and thank you, Brandy, for all your help today. I hope I am sounding okay. Welcome, everyone. I cannot see the chat as I present, so Brandy, I believe, is going to be moderating those questions if things come up. I do enjoy answering questions as they arise, just in case we run out of time, so please don't hesitate. And I'll begin. I am housed in the Department of Health and Human Services, Division of Public and Behavioral Health. We have an office in Reno and an office in Las Vegas, but we are covering the entire state. I thoroughly enjoy traveling across the state and working with our rural communities. And I look forward to this moment of time with you in these very strange times. So I know there's a wide array of skill around suicide prevention participating in today's webinar. I had designed this for those who have never had suicide prevention, all the way up to those that have. So from seeing who has registered, I think there's great experience here. So I might skip over several things that are pretty basic. But if I skip over something that you're concerned about, please ask a question in the chat box. So we're going to talk about the most recent suicide statistics, and the Nevada Primary Care Association had asked me to focus on youth suicide prevention a little bit, so we will touch on that specifically. I'm quickly going to go over our suicide prevention plan and current initiatives. I know there's a lot of concern around the pandemic and mental health and potential impacts of the pandemic and economy. So we'll touch on that, as well as what to look for and how to help those you might be concerned with. Then we'll take a break, and then I'll bring in Zero Suicide and Crisis Now, so you know that's coming your way. The mission of the Office of Suicide Prevention, as I mentioned, it's statewide. It's a lifespan mission. We are currently in the process of submitting for multiple grants, which I'll go into in great detail. most of which will help us develop a new updated suicide prevention strategy for the state. We also have the Nevada Coalition for Suicide Prevention, which is a wonderful public-private partnership helping us host training opportunities as well as public awareness, such as the Walk in Memory Walk for Hope that has been in multiple communities across Nevada. They're a wonderful partner in bringing advocacy and public awareness to our state around suicide. In 2018, vital signs came out from the CDC talking about the national suicide rate from 1999 to 2016. And Nevada, as you can see, a rare occasion when our state is not standing out in a negative. We were the only state in the nation to decrease our suicide rates by 1%, where currently the national rate has gone up about 36% since 1999. To be fair, Nevada had one of the highest rates in the nation at that point in time, so we had much further to come. But considering our barriers to access and barriers to other suicide prevention efforts over the past 2 decades, it is still quite stunning that we have held steady and even decreased a little bit. I really attribute that to the community partnerships and grassroots efforts and those of survivors of suicide loss who really drive prevention efforts. Currently, we have 2018 data. I apologize, that title did not get changed, but in the chart, we did acknowledge the 2018 data. So the very top purple line is our Nevada rate. So you can see the really kind of coming at the same place from 1999 to 2018. The red line is our Nevada firearm suicide rate. It really is a driver of our overall rates, where currently about 57% of all suicide deaths are by firearm. Below that, the green is the US national rate of all suicide deaths, and you can see how it's ticking up there. And below that is the green US firearm deaths. So they kind of mirror, the firearm mirrors the overall suicide rates, where the national firearm rate, I think, is about 51%. A couple years back, Nevada had reduced our firearm suicide rate to 51.2%. We had made a dramatic decrease in that, but it has risen back up in the past few years. So when we focus on prevention efforts around lethal means safety, we can incredibly impact both safety and our rate. Here, more specifically, for the United States, over 48,000 suicide deaths in 2018. That is more than one jetliner crashing per day, which is really shocking when you think of one plane crash. That's what we know of suicide loss. 3.6 male deaths for every female death. That holds true for Nevada, where it's about 77% of all suicide deaths are male. And for our, currently, we are the 8th highest rate. Suicide is the 8th highest rate for the nation with Nevada. And I need to step back and say that again. It's really difficult to not look at faces when I present. I'm so used to having people in the room. Nevada has the 8th highest rate in the nation. Suicide is the second leading cause of death for people 15 to 34, and it is the leading cause of death for our youth ages 10 to 14 years of age. For decades, Nevada's elderly have had one of the highest rates of suicide. Currently, I think we have the second highest. We are hoping to tackle that with some of our new grants that we have submitted. And we lose more people to suicide than car crashes and homicides combined. This is a little breakdown of seniors 65 and over. Our Nevada senior rate is double the senior rate of the nation, and it's really shocking. Part of that, I believe, is the ruralness that, you know, Mountain West region has higher rates in general, but we have rural communities where access is much more challenged. I would say our stigma is still high, and we need to keep breaking that for mental health, substance use, and suicide. One elder suicide almost every hour in Nevada. And what's important here, often there is a mental health concern, not always, but untreated and undiagnosed depression is one of the leading causes for our elder suicide. We can absolutely improve the prevention rates with that. help is available. Veteran suicide rates are high for Nevada as well, and we have two charts here. One are the counts, the other is the rate. And when you look at pure numbers, those over 60 plus have higher numbers of suicide deaths, but our younger military and veterans have higher rates. So we pay attention to the entire spectrum of that. We have two initiatives, Mayor's Challenges for service members, veterans, and their loved ones, their family members, and also the statewide Governor's Challenge. We also are currently working toward a third Mayor's Challenge somewhere in Nevada. But these efforts are public-private, incredible partnerships developing implementation plans to tackle SMVF suicide prevention. So I hope you are looking out for those efforts. Often it's about lethal means safety, building connectedness within communities, peer supports, and natural community supports, as well as hoping to increase access for mental health services and healthcare in general. So you'll see over the past several years where the veteran rate has gone for Nevada. The lower line is overall suicide rates in Nevada, and the upper line, we're double our veterans rate. So we really need to surround those families and those individuals with all the supports possible. I also want to bring up as I mentioned, stigma across Nevada makes this conversation very difficult. The taboo is quite profound, especially in different cultures where it's difficult to talk about suicide for fear of bringing it upon a community, also for uncertainty of accessing help that will speak to diverse cultures' needs. But for our physicians, healthcare providers, it is also highly stigmatized, but we lose over 400 physicians by suicide annually. With this extreme crisis and pandemic and the demands on our frontline workers, we really need to pay attention and have these conversations about keeping our frontline workers, healthcare providers safe. So I didn't want to ignore that in part of this overall conversation. At the end of the presentation, there are several specific resources for our healthcare providers that can be accessed immediately. As we talk about youth, we see the trends. Now, these are national statistics. We see the trends start to tick up around 2012, 2014. Now, if you think about what might be going on at those times, social media, as well as increased use of technologies are starting to occur. We do think that might be an impactful part of the increasing rates. Also, lots of stressors for families that might be trickling down and impacting our young people. Nevada shows similar statistics where 2018 was incredibly high for our rates, where we went up by 60% from 2017 to 2018, and in Clark County went up 90%. They did come back down the next year, so we try and investigate what might have been happening. If you think back, 2017 was the mass violence in Las Vegas, and that impactful event could have impacted our youth rates. The Child Fatality Review Committee and the Suicide Fatality Review Committees have investigated multiple suicide deaths to see what the risk factors and potential prevention opportunities might be for this, and they put out a report last year. But technology was a big part of this. And you see that uptick again starting in 2014. Here's our Nevada-specific rates. As you can see, we had in 2011 a tremendous jump, and then again in 2018. Those are the big peaks there. What happened in 2011, you'll hear me mention risk related to media contagion. In 2010, some of you might recall, there were multiple high-level national suicide deaths reported. Anywhere you went, it was reported bullying and suicide, and a straight line driven. There was a death in New York by a young college student, and then there was another death in, I want to say, Maine or Massachusetts, of a young Irish girl who had just come to the United States, and they called it bullicide. Every day in the news, on social media, they mentioned these bullicides, bullying and suicide, and our rates tripled the next year. They came back down, as you can see, in 2012, but I can't think that it wasn't part of media contagion. At that same time, we also saw an increased spike because of the recession on homicide-suicide, especially in Clark County. I think there were 10 homicide-suicide situations in 2010 where they would say someone lost their job, killed their family and themselves, or lost their house. Suicide is very, very complex, and rarely is there one circumstance that is triggering this event. It does happen, but typically there's many things occurring before that person lost their house or lost their job. But the more the media reported on it, the more they occurred. People will think this is my option. So that's what happened in 2011. And then I think that the trauma possibly could have happened in 2018, but it's still too soon to tell. And if there are any questions, I can take a pause right now.
I do not have any in the chat box.
Thank you, Brandy. Okay, so I wanted to bring this up because I know for Nevada, it can be hard to build access to healthcare, especially mental health care, bringing our workforce to a broader ratio of meeting our residents and the needs they have. But there was a TED Talk that I absolutely loved. It warmed my heart, out of Zimbabwe. The psychiatrist was the only psychiatrist in Zimbabwe, and one of his clients had made a suicide attempt. She survived, and he was working with her and the mother to keep her safe for about 3 weeks till he could get her into an appointment. He did not live in the city that she did, and he was working with them and talking regularly, and 3 weeks later the mom called and said her daughter had died by suicide. They could not afford the bus fare to get to his office for his treatment, and she did not make it. And it just devastated him because he was the only one for many, many people needing help. His answer was to work with those community natural supports of Zimbabwean women, grandmothers specifically, and train them on what to look for and how to help. They were community members who would sit on a bench and just be there to listen. They had a term, I want to say overthinking. They don't have a term for depression, but it was overthinking. And they would listen to those who were struggling with that overthinking. And the research results showed impact equal to that of clinical or even better sometimes. I just wanted to put that out there that we can get creative as communities. Mental health, overall health are crucial to the well-being and keeping people safe, but they aren't the only answers. And when we build a community safety net, looking at these creative ways of connection and supports, it can really strengthen the nets we have out there and really build that connectedness. I think is one of the best proven prevention strategies that exists. So please look for that TED Talk. It's just delightful. Some of the suicide prevention initiatives we've been working on for years. The office began in 2005, and we continue to keep growing, not only because of demand for services, but also the stigma has reduced, and more people are wanting to be a part of this. They know there is a need with anxiety and depression rates increasing. So we work in the schools with signs of suicide in many counties across the state for education of the students and showing them how to help their friends or themselves, but also screening if schools would like that level of care. And we partner with community-based services to help with the screening programs. We have youth mental health first aid trainers all across the state. We really built this program up with Project Aware through the Department of Education, where they really began to build social workers and other mental health supports within the schools. And then our job with Office of Suicide Prevention was to increase community mental health literacy, and the youth mental health first aid training is an excellent way to do that. It does cover suicide prevention, and that does cover the mandated CEUs if anyone is interested in bringing that to your communities as we begin to open up with trainings. We also are looking to increase adult mental health first aid. Most community prevention coalitions did have trainers in this. And we want to keep building that up because we can have modules focused on opioid use, rural communities, veterans, primary care. There's specific modules that adult mental health first aid can focus on, and it will continue to build those caring communities we'd like to see. We all need to be a part of suicide prevention, and I think these are great ways to become informed on what to look for. It becomes less scary and really reduces that help-seeking stigma. We have worked with the Suicide Prevention Lifeline, or Crisis Support Services of Nevada, for many, many years. They are currently over 80,000, actually. I just heard Rochelle speak yesterday. 80,000 contacts that this small center in Reno handles, and they're just tremendous. It's not only suicide prevention and mental health, it's also sexual violence prevention and supports. Any kind of crisis they're there to help with. They have a support group for those bereaved by suicide. So they're an incredible partner. And we were one of the, I think we were the first crisis center to do crisis prevention through texting. Now they have a national crisis text line. So there's many supports out there for people 24/7 if they need it. Some of the training, I won't go into this in great depth, but since we have begun and our training in 2006, it's been well over 70,000 Nevadans trained in one form of awareness or education. I have a list, a menu of our trainings at the end of this, but some of our favorites are really the Safe Talk and the Assist Applied Suicide Intervention Skills Training through LivingWorks. They really equip someone to be ready, willing, and able to intervene when they are worried about someone. Unfortunately, those LivingWorks trainings are face-to-face, so we've had to put those on hold, but we're building a training plan to bring it back slowly and safely, starting pretty soon, I believe. We have also partnered with local community groups, task forces. Elko and Winnemucca have zero suicide focused groups. Humboldt Connections, they're doing amazing work locally. Suicide Prevention Network in Douglas County has also been around. They were the first to really focus locally on that community planning and supports, and we want to keep building that, making sure we know what's happening nationally, bringing that to inform our state strategy, and then making sure we work with the communities to pull out what's going to be helpful for them locally. The Service Members, Veterans, and Their Families initiative started in about 2012. Dr. Luana Rich did the first epidemiological report on Nevada veteran suicide rates, and it really caught the attention nationally. And so we were invited to participate in academies. And we were partnered for 4 academies in the past. And of course, the phone rings right in the middle of a presentation. But recently, with Kim Donahue, who's the suicide prevention coordinator with the Department of Veteran Affairs, was huge, instrumental in getting the mayor's challenges in Clark County and Truckee Meadows. And because of the incredible work through those cities, we got the governor's challenge. So you'll be seeing very detailed strategies coming forward. We're seeking grant funding to support the initiatives, as I mentioned, around building access to healthcare with some zero suicide work, hoping to develop workforce so that our service members and veterans can get into the help they are seeking, and lethal means safety. You can see down below, reducing access to lethal means. We have worked for years with gun shops and gun shows to make sure those who do keep firearms in their homes, how they keep them safely, but also what to look for if they're worried about a loved one. We know if we can build space and time between that person at risk or with thoughts of suicide and that means, be it medications or firearms or others, often we can get them through the crisis safely. So it's really crucial, especially if you're aware that someone's struggling in your home, to lock them up, or better yet, get them out of the home into someone else's house until your loved one is safe. The Office of Suicide Prevention works with Child Fatality to buy gun locks and medication safes that we share with mobile crisis. So if a family has called out for help with our DCFS mobile crisis response teams, or they have been discharged after an attempt, we want to make sure these safety measures are in those families' hands. That, with a good discharge and safety plan, can really improve healing and recovery for that young person and the family. Finally, you're going to hear later that continuity of care with Crisis Now and Zero Suicide. We have a Zero Suicide coordinator working with us in Casat, who has done an amazing job. Sherilyn Rarwood has reached out to multiple facilities across the state, done workforce surveys to find out where facilities are with their attitudes and training about suicide and bringing it to the facility as a whole. And then making sure the communities surrounding those facilities are prepared with crisis supports. I don't think I'm going to go into the facts in great detail because I imagine most of you have had this level, but I want to emphasize few suicides happen without warning. I know we often hear we didn't see anything, and I get that. That does happen, especially it's really difficult for families to recognize when there's signs of risk for suicide or other issues because sometimes we miss it. Or maybe they aren't showing us those signs. Maybe they're protecting us and showing others. So often there are signs, but we don't always know what those are to look for. And people with signs can be very creative. And they might show one person one sign and one person a different sign, and we don't put them together. We don't think often those signs are enough to worry about such a scary thing as suicide. So we want to keep getting people the tools to know what to look for and how to help. Another big myth I want to break always, it still happens quite regularly, is that if you talk about it, you will cause it to happen. You will plant the seed. The majority of people desperately want to talk about it. They don't want to keep it inside themselves. And so the biggest gift you can give someone you might be worried about is to ask directly. What that does is it gives them permission to be honest. And it gives them hope that they're not alone in this struggle anymore. It also helps them know that if they can talk to this person about it, then maybe they can talk to others. And that brings safety. I will emphasize suicide is highly preventable, but not always. We are going to lose people even when we do everything possible that we think is right. It still can happen. And we have to then prepare ourselves to take care of ourselves and seek the help in our healing. I want to talk about showing a marked or sudden improvement after a suicide attempt or a long depressive period. That is an incredible sign we often miss. Again, if they have been struggling with depression for a long, long time, we're hypervigilant. And then if they start to feel better, we kind of let our guard down. It can be exhausting to be a caregiver. So we let our guard down. That might be a time of risk. Suicide is not, most often, not about wanting to die. It is about wanting to end pain, be that physical pain, mental and emotional pain, spiritual pain possibly, or all of the above. Overwhelm is often a part of this, where there are coping strategies and resources, but there's so much overwhelm that those support systems or coping strategies can't even be accessed or seen. So we have to help them reduce that overwhelm. And I will also say a big part is feeling like you're a burden on your loved ones, on the world, on your community. We have done research on those who have survived attempts by suicide attempts, and two things kept coming up time and time again. This was not about wanting to die, it was about wanting to end pain, and I knew my loved ones would be better off without me. So when we think about that and someone feeling like a burden, as an intervener, we can help find out what would it take to not feel like a burden. We can work with that. What would it take to not feel overwhelmed? One of the biggest parts of not feeling overwhelmed is having that person reach out and talk about suicide, and you're not alone. Instantly, that helps in not carrying that heavy burden and feeling overwhelmed. Last one I'll cover, suicide is not just a way to get attention. I truly believe it's about attention needing. There are unmet needs, and we can figure out what those unmet needs are. We might be able to help with that healing and recovery in a much safer way. So if you see someone coming back to thoughts of suicide or multiple attempts, what are we missing that they have to attempt again? We have to figure out what those unmet needs are. So if there aren't any questions, I'll move into risk factors and warning signs. I guess I should check on my time frame. Okay, we're about halfway through. So risk factors, I mentioned that vital signs report in 2018, and I found this information incredibly powerful. It's something we always knew, but it was important to see it shared in this report. 54% of people who died by suicide had no prior mental health diagnoses. Now, that doesn't mean they didn't exist. It could mean they didn't access help or receive a diagnosis. But also, mental health, while an important part of thoughts of suicide and risk, there are also environmental aspects. those daily stressors that really are a huge part of that immediate crisis. So while someone might have an underlying depression or underlying mental health concern of another type, what is it that wears and tears on our wellness overall? It's relationship problems, financial stressors, housing challenges, all of the above put together, what we're thinking about right now, isolation. Those triggering events are really important. And so we need to make sure we could help them get connected to mental health supports and medications possibly that will help, but we can't forget the environment they might be going back into. So if it's a young person going back into a home where maybe there's a lot of stress or violence or trauma, we have to focus on that as well, or those thoughts of suicide and risk are going to continue on. The Vital Signs report also gave us recommendations of what we can do, and many of the grants that we've seen in the past few months really emphasize this, strengthening economic supports. It's tackling the stressors at multiple levels, not just access care and mental health, but their environment. So I think this is a really powerful thing to remember. Promoting connectedness, one of the big ones, be it community engagement, be it peer norms. How do we feel about help seeking? How do we feel about those with substance use, mental health concerns, or thoughts of suicide, reducing that stigma and taboo? We do a lot of help with identifying and supporting people at risk. So training, gatekeeper training. With Zero Suicide, it's training providers extensively. So you'll see a lot of that. And then finally, lessening harms, preventing future risk. Some incredible options there that we need to build across our communities are postvention. So after someone has lost a loved one to suicide, we do have survivor support groups for bereavement across the state, and they're incredibly helpful because suicide loss is such a unique experience. You have feelings of anger, confusion, guilt, and also your own thoughts of suicide sometimes. So we want to make sure survivors of bereavement are protected, but also post-attempt, making sure that person gets the right help, making sure their environments are made safe can reduce the risk of future repeat attempts. So lessening the harms is really an important program we can build. Other risk factors, I think I've covered pretty well: the high stressful life events, loss, any kind of loss really, that contagion we talked about, the lethal means are the biggest, most impactful risk factors. Another one I wanted to touch on is chronic pain. I know this touches me very closely with a loved one, and chronic pain really impacts how one sleeps, how one moves through the world and copes with things. And then I know insomnia can impact risk for suicide. So if people aren't getting good sleep, they aren't building up those strategies that would keep them safe. They aren't utilizing their typical escapes from pain and safe escapes from pain. They possibly aren't able to think about their support system. So we need to think about, with our opioid risk in Nevada as well, anyone with chronic pain should absolutely be screened for thoughts of suicide. Other links, those deaths from despair you've been hearing a lot lately, with increased deaths from alcohol and substance use and the suicide. It's not inevitable. We have to know that people are struggling and reach out and connect them to what might reduce that despair, what give them relief from that despair. Suicide, someone with chronic pain is twice as likely to consider suicide or die by suicide. With an opioid use disorder, it goes up to 13 times that. So again, paying attention to thoughts of suicide with an attempt from substance use, be it opioids or another, we should be screening for suicide because those risk factors are so tightly linked. Just asleep, we have to help them find ways to deal with that sleep, be it meditation, mindfulness, other cognitive treatments that might help with this. Really important because, again, if sleep factors continue, their ability to cope and get through crises will be diminished dramatically. Protective factors, receiving effective mental health care, and I would say healthcare in general. problem-solving skills, starting really young. Communication and ability to cope really help build that resiliency. We all get through hard time, or we have hard times. But if we aren't able to cope as hard times come, or again, if we're having health, other stressors, and sleep issues, our typical problem solving is not accessed. Connectedness, be it to family, community, spiritual connections. For me, it's nature. That grounds me every time. We really can get someone through a hard time. I think I've covered this enough, but we can't emphasize it enough, especially with our young people. There's been research with LGBTQ who have higher rates of suicide, higher thoughts and attempts. And what was protective was how their experience was and how their support systems handled their coming out. If there was support and acceptance, that was protective. If there was rejection and bullying, absolutely increased risk. So we want to pay attention to building that connection and safety, especially around LGBTQ. So if you are worried about someone, this is a really basic Nevada model. We want to show you care, letting them know you can handle this conversation. Really, you're paying attention to the signs. So you might see changes. And I will say transitions are a big part of paying attention. So it could be transitions from elementary to middle school, middle to high school, and high school out into the world. It could be heading into the military and maybe overseas, or returning. Big transitions there. Of course, retirement. This was your world, your identity. So transitions during retirement, health challenges and the transitions that might be a part of that. We want to pay attention. It doesn't mean there's risk, but again, we want to make sure people know we care and that they're not alone through these challenging times. So you notice transitions, you share observations. Any change is something I like to just make easy. So any change in appearance, mood, or behavior, along with those transition life circumstances or losses. So maybe they run every day and they've just stopped running, or you meet them every Friday for breakfast and they've stopped coming. Texting nightly and that hasn't happened. It doesn't mean necessarily we jump straight to suicide, but something's going on and you need to check it out. Maybe they're ill, maybe they've had a loss or a different change in their life. So you're showing you care by paying attention. I noticed you haven't been meeting me for lunch for several weeks now, and I really miss you. What's going on? So you're sharing the observation instantly. For someone who might feel invisible, a burden, devalued, instantly you're countering that by saying, I see you, I hear you. We go in social media and you'll see people post, I'm so tired, ... I'm done. What a terrible day, ... They're desperately wanting someone to reach out to them. What we typically do is say, oh, it's going to be fine, you're okay. Here's a little happy cat picture. They want someone to have this conversation and say, what happened? I always go into private messaging and say, I saw what you posted and I need to see, I'm worried about you, what's going on? And it might be to the point of I need to ask them, are they having thoughts of suicide? But they desperately want someone to recognize it and not invalidate it, not take away their pain, their tiredness. They want someone to hear them. And so that's how you show you care best. Instantly, again, you're giving them hope that if one person recognizes that they're challenged, maybe there's others. Now, I'm going to turn this over to Brandy. This is a beautiful, brief video by Brene Brown on the difference between empathy and sympathy.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, No, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, is an empathic response begin with at least. I have it, yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. At least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, what would you say? I don't even know what to say right now. I'm just so glad. Because the truth is, rarely can a response make something better. What makes something better is connection.
Thank you so much, Brandy. Okay, let's see if we can do this seamlessly. Excellent. Okay, are we back on track?
Yes.
All right, thank you, Brandy, so much. Absolutely warms my heart when I see that we really don't have to have the perfect answers. It's that being present, just listening and not trying to take away the pain. They need to get that pain out. They need to release it, to find their coping strategies, to find their hope. It is in there, but that pain is so overwhelming and it buries it. So truly that video explains what a gift we can give. I noticed some questions in the chat about COVID response. So I'll address that now so we don't forget. From day one, we've been working hard with the Behavioral Health Task Force in response to COVID, also with emergency management to build up Serve NV, which is a place for healthcare providers and others to go to volunteer. It protects them under the emergency declaration. So we also have non-clinicians who can volunteer and do psychological first aid. We have written 3 emergency grants, mostly around mental health and suicide prevention. And we just, I believe, heard word that the suicide prevention one was funded the other night. So you're going to see not only were there hotline and warm lines developed and mobile crisis was bumped up in the first go of the emergency funding. But currently we're going to hire crisis counselors to be spread out across the state. So typically, like with Katrina, you'd have crisis counselors there on the sites that had been impacted. This is a unique kind of disaster with more long-term. So those will be embedded. I don't have all those details yet, but I can absolutely get those to you as this grows. It's a very rapid moving funding source to deal with immediate, and then it'll be built out over the months to extend what we might see coming down the road. We also developed a warm line for the healthcare providers that I mentioned. That was UNLV in partnership with some of this emergency funding. And that line is at the end. So you can please share that with healthcare providers who might need it under these unique circumstances. And then we have submitted grants for youth, older adults, and comprehensive suicide prevention planning, as well as a grant for zero suicide, which would impact healthcare systems. So a lot has happened. I will say hotline calls have gone down specific to suicide. You'll see more with basic needs, calls about anxiety and depression, of course. That isolation is really real. That loneliness is huge. The NAMI warm line has seen an incredible increase because of that loneliness. Calls to, I want to say, deaths. They just reported deaths in Clark County for February, March, and April have been down compared to the same time last year. So I think what we're probably seeing is that coming together in a crisis and really being supportive of those with difficulty and just surviving right now. But as we know, the economic hardships that might impact us could lead to challenges that might increase risk. I want to say could because it is not inevitable. We know the 2008 recession had impact. Economic recessions and the Depression did have impact on suicide and mental health. But if we build our support systems and safety nets in our communities, it doesn't have to be that way. So I just want to emphasize that. So back to the model, you have recognized someone's having challenges. It could be they seem ill, they're isolating, they're withdrawing, they're gathering means. You know they're in transition. Maybe they're going through a breakup or a divorce. Maybe mom's deployed overseas and their stressors at home. So we want to pay attention to the transitions, and then we use those changes to ask directly about suicide. I know this question feels heavy, it feels intrusive to people, but it is, as I mentioned, a gift. You're not asking out of the blue. You're asking because you've noticed challenges, you've noticed changes, and you're worried about them. So we ask directly. I know you're withdrawing and you're having trouble in school. I also know you had a breakup recently and you mentioned some bullying. I'm really worried about all of these things going on in your life. Has it been so hard you're having thoughts of suicide? The fact that you have all those changes you've noticed shows that you were paying attention, you're listening, shows they're not invisible, which is huge, and that you're not afraid to have this conversation. That confidence in asking about suicide directly gives them absolute permission to be honest, that they're not going to be a burden on you either. When we ask about suicide and say with our head shaking, you're not thinking of suicide on you, are you? You're not thinking of doing anything stupid, are you? We're blatantly telling them we don't want to know the truth because we can't handle it. And knowing that they don't want to be a burden on their loved ones, they're not going to tell you. But they want to tell someone. So I hope that helps clear up the ask. And if we're wrong, it's okay. What if you ask about suicide because you're seeing these changes and they say, no, I'm not having thoughts of suicide. I'm so glad you're not having thoughts, but I'm still worried about you because I'm still seeing these signs that you're struggling. What do we need to do so that it doesn't get any worse for you? At least asking, we get out on the table what's really going on. And they know if it ever escalates to thoughts of suicide, they can trust you. They know who to go to, whether it's for them or someone else they know. I've learned, just by asking, I ask anytime. I'm really comfortable, but it might be often that they connect me to someone they know, a colleague, a friend, because they know I can have this conversation. So you're building up that support system for them, whether they are at risk or not. Often, once we know they're having thoughts of suicide, we want to find out about a plan because then we can develop a safety plan. So when we do our ASSIST suicide intervention first aid training, we first find out why suicide, why today. So that's a whole different training I'm not going to get into today, but what's important is we want to know why they're thinking of suicide today. I got that from working on the hotline for many years. We weren't there to do any therapy. It was in the moment. What made you think of calling today? What made you think of suicide in this moment? Because we can focus on that immediate moment, get them help for that, and then connect them to resources for other stuff going on in their lives. But for the moment, it's that crisis we want to focus on. So we would often hear that. And then with the more listening about why suicide and their story about suicide, we hear their reasons for living. And once we hear their reasons for living, you hear uncertainty. When we get to uncertainty, we often can say, I hear that you have lots of pain and reasons for dying, but I also hear you have support systems and loved ones and reasons for living. Can we keep you safe for now until we can figure out what else is needed? And once they agree to that, we can develop an incredibly strong SAFE plan, which is detailed. Their internal resources, their external resources for support, hotlines, doctors, what else will de-escalate them in a time of crisis. And we check in on them and follow up to make sure that plan works. So I think we've covered that. So we ask the question, we find out what's going on and how we keep them safe. And we're going to connect them to help. So here are many of the typical resources we would reach for. The Suicide Prevention Lifeline, 24 hours a day, anywhere in North America, you can call that number and get connected to help. They can also reach out for you. So say I was worried about my brother in New York, I could give them the information and why I'm worried, and they would reach out and check on him and do an assessment, often an assist intervention. If you are a service member or veteran, you can call that number and press 1, and you get clinical level care with responders who are excellent with traumatic brain injury, post-traumatic stress, military culture, other needs specific to service members or veterans, and then they can connect directly to the local VAs and get them into care for safety almost immediately. That's an excellent resource. Not all service members or veterans want that, so they could just not press 1 and get just the Suicide Prevention Lifeline. There is also a disaster distress line I did not put on here, but I can get you that. For those in times of COVID, we were putting that out a lot, and they were getting a tremendous amount of calls under these circumstances. We also have our MOST teams for mobile outreach and our mobile crisis support teams for youth. So under 18, and then we have care teams out in the rurals, which are for adults, and you access them through the Crisis Support Services of Nevada. So many opportunities. They are doing telehealth right now. So if you're worried about someone, I talked to a gentleman who's worried about his daughter, and it didn't sound like she was in immediate risk, needing hospitalization, but maybe needing an assessment, and so mobile crisis response could do that by telemedicine. So I think this pandemic has forced us into circumstances that we weren't certain about that have been incredibly helpful. I know telemedicine was not loved by many people, but what we're hearing now, it's incredibly appreciated by many people. They don't have to find transportation. They can be in the safety of their home with their pet nearby, things we didn't think about in the past. So we might hear challenges from some, but I think we're also hearing equal gratitude for this opportunity to reach out for care through telemedicine. The Trevor line is also 24/7. It is for LGBTQ youth, an excellent resource. And I have a little typo there, but you have Reno Behavioral Health in the north and Desert Parkway in the south. We were worried about connecting those with acute risk for suicide to emergency departments. It was a real dilemma on what's safer to try and de-escalate them through the conversation or other ways, or send them to the emergency department where they might be exposed to other risks. This was at the beginning of the crisis when we really didn't know what was happening. So they developed options for Reno Behavioral Health and Desert Parkway to have people with acute risk go there, informing them they're coming, but they go straight to those facilities for care. And I think it really alleviated some of the concerns for health dangers with COVID. All right. Those are the additional resources related to the disaster. Excellent. There's for hearing loss and deafness if you call. The NAMI Warm Line is wonderful for those not in acute crisis, but maybe needing some help with anxiety or depression or just connectedness. Excellent resource with peer support. Foundation for Recovery at the bottom also has incredible support for those in recovery. I know this has been a hard time for those living with recovery and used to community supports and groups. It has been a challenge, but they are an excellent option if you know anyone worried about that. And then Crisis Text Line. Not only can you get help through texting 24/7 anywhere in the US, if you are wanting to give back in this time and be a responder, Crisis Text Line offers a 30-hour training if you go online to their website, and you can become a text responder after the 30 hours. It's a one-year commitment, but I think what a great opportunity. People have time on their hands, some of them, and want to give back in this way. So I do encourage that. I would also encourage looking at ServeNB if you are clinical and might like to offer services for behavioral health emergencies. These are some of our other training opportunities with the continuing education mandates and medical education mandates. We want to make sure we're offering you ongoing evidence-based trainings. Assist and Safe Talk, as I mentioned, are some of our favorites. They're international state-of-the-art trainings, and they continue to improve. They just change how you handle helping someone with thoughts of suicide, and you really feel confident and competent in that outreach. HAMS Online for clinical professionals, it's a framework for helping someone with thoughts of suicide. What we know, and I will talk about with Zero Suicide, is treating the suicide directly is really important. And CAMS is a framework that works on suicide directly. It also has lots of language that is similar to the LivingWorks models of Assist and Safe Talk, talking about reasons for dying, reasons for living, drivers, which are stressors. And for some, as little as 4 sessions can take care of their thoughts of suicide, and then they are connected to other modalities that might need to be dealt with. I will say dialectical behavioral therapy is also another option. It's more long-term, but it's incredibly effective with thoughts of suicide. We work really well with CASAT and their beautiful online trainings and face-to-face trainings. And so to access some of those, we have a Nevada website I will show you next. Counseling on Access to Lethal Means. It's about a 90-minute training. I'm trying really hard to get certification so that can be included in our CEUs, but it's a national training, so that's been a challenge. It is free. It is excellent. I encourage any provider of healthcare or mental health care to take this. It helps you talk to your support system, who this person with thoughts of suicide is going home to make sure the environment is safe. And this is the Nevada Intervention Connection with the website down below. We developed this through Project Aware to make sure those with youth mental health first aid could get recertified easily, but it also shows our LivingWorks trainings through the Nevada Coalition for Suicide Prevention. We have a portal to the CASAT trainings, and we have portals to Zero Suicide that we're going to keep beefing up. So as you need to continue to get suicide prevention education, we want to keep this site full of interesting and evidence-based programs. And on that note, we are ready for a stretch break. Oh, we're on time. So I thank you for your attention, and we'll see you in about 5 minutes. Okay, welcome back, everyone. I know there was some questions with Dr. Ackerman in the chat. Also, if more questions come up towards the end, I can probably don't have all the details on the top of my head, but can easily email them to Brandy right after or get you documents. So now we're going to switch into the crisis now mode. As you know, there's a mandate that came out of this because we knew that over 45% of those who took their life saw their primary care physician within a month of their suicide death. And they say almost up to 70 to 80% have sought care within the year. So we knew we were missing an opportunity for prevention. We had an intern from the School of Public Health Sciences, and she did a detailed study with the Washoe County Medical Examiner's Office looking at 2017 suicide data, and our data held true to that. We lost 21% of all Washoe County and some of the rural counties suicides within 24 hours to about a week after they had seen someone. There was 11% within primary care and about another 11% within emergency departments and acute care facilities. So we knew we were going to have to find a way to tackle this and not miss those opportunities. So we have some national recommendations. The holistic public health approach is looking at integrated patient-centered care, pain management, absolutely, it's so linked. The suicide prevention has to be a part of this. Addiction care and medical care are needing to come together. And some of the recommendations from the standard care elements are specific to these 4 environments: primary care, outpatient behavioral health, inpatient behavioral health, and emergency departments. So I'm just going to go over this really quickly, but can get you the document. It's sourced down below on the slide. So one of the gaps is not proactively identifying intense suicide risk. Identifying suicidality in all patients with mental illness or substance use disorders, we need to be doing that. We need standardized tools that do exist out there. There's some incredibly well-evidenced tools that can be used. And then we need to build in that care transition process within the facility, but also back from the facility out into the community. And so we're going to move into that with Crisis Now and Zero Suicide. Safety planning should happen consistently, whether it's with discharge planning or the emergency department, with the family. We have lost several people several years ago in Nevada within 24 hours of being released from an emergency department to suicide. They are being released home and alone, which I totally understand is a very difficult gap to bridge. But we need to be building in resources for support, whatever that might be. If they're released to a homeless facility, for those unhoused, we need to have someone there who can check in and make sure the safety plan is being utilized, and if not, getting them back in touch with the care that will keep them safe. And absolutely, with every interaction, there should be lethal means safety discussions as part of that safety plan. Getting those medications locked up, getting that firearm out of the house or locked up when someone's in a crisis. And often suicide is not a constant. It is a buildup, a buildup, a buildup, a peak in the crisis, and then a de-escalation. I'm hearing more and more about chronic suicide. But again, those with chronic suicidal thoughts might have a different look to that acuity. So they might think of suicide daily, but they are not actively planning on it. They might be more ambivalent about living or dying, but we'd never disregard either. But I am seeing more chronic suicide. So if you're thinking about those acute levels where they're building up to a peak and a crisis, having the means locked away or out of the house really, really increases that safety dramatically. Making appointments so that if they're leaving care, they have warm handoffs to that next step. I know when I've experienced discharge at facilities, I get a long list of hotlines and places to call on a piece of paper. Even working in the field, that's not always easy to navigate. You don't know who to trust. You don't know who might be good at this. Getting in, and those waits were overwhelming. So the warm handoff and those caring contacts during transitions can be absolutely life-saving. Maybe we do have to wait for months to get into the appointment, but what's happening in between those 2 months that is helping keep that person in recovery and healing and working their safety plan? So Crisis Now model and Zero Suicide. We are working tirelessly as a state to bring Crisis Now into our communities at the state level, but within the Office of Suicide Prevention, we are working with our health facilities to build this in. Thomas Joyner is one of my absolute favorite suicide prevention researchers. He really is the one who talks about the perceived burdensomeness and thwarting belongingness. Then you have a certain level of fearlessness about pain, and that very dangerous spot in between where you add the means. And that's where that risk is most high. But where I really came out of his theory of interpersonal psychology was the burdensomeness and the connectedness that we need to build. And that's really something I have noticed when talking with people with thoughts of suicide. And if we can alleviate that sense of burdensomeness and we can build connections, whatever that may be, it can really increase that safety. I'm going to skip that. So some of the training and skills we want to see, definitely people need to know how to engage and assist those. This is such a scary topic, even for those in the mental health fields. Often we are scared about liability. I get it. That's a big concern, but to the point where it might shut us down from hearing what this person might need to talk about, why they're having thoughts of suicide and the reasons for dying. When we don't hear that and we focus on the safety, great, they're safe, But then what often happens is they're released with the same thoughts of suicide, and you see those repeat attempts and reoccurring thoughts. We have to get in there and really hear their story about suicide to know how to build the best safety plan and connect to the best resources for their future safety. Crisis Now really helps a community build those crisis supports within the community. So when they're identifying someone with risk, we take them to the least invasive form of safety. Help can sometimes be traumatic. And if you have increased risk of suicide because of trauma, and then you're put into circumstances that add to trauma, it's not really therapeutic, is it? So we want to make sure we're developing a crisis system that is more therapeutic and safe for that person at risk. So in the past, it was one size fits all. We really had one place that would handle crises. Often it's the emergency department. And as you know, in Nevada, our emergency departments had been overwhelmed many years. And so I know friends who have had their loved one in there for 9 days, sometimes even more, waiting to see someone, waiting to get a bed. I had a very profound conversation. I got to speak at a nursing symposium a few years back. And right before I spoke, a white paper came out from Beacon Health Systems. And they talked about how in the past 10 years, deaths from heart attacks decreased by 40% because they found a technique that could go in rather quickly and protect the heart muscle from damage. Where in the past, they would wait for the right team, they'd run tests, that heart muscle was languishing and dying, and the risk was increasing for death. We really see that with suicide too. We wait to talk to that mental health professional. We wait to get them out into another facility and another bed. And often they could be there for days not having this conversation about their thoughts of suicide. Maybe because workforce is stressed. Maybe the demands in the department are high, absolutely. But that is traumatic. And I think the belief that help is available starts to languish and die as well. What else is languishing and dying in that time when no one's having that conversation with them? I've had people say, we just wait to get them out to the next place. I think it's part of the stigma around suicide. And when I can work with people and tell them it's not about the wanting to die, it's about unmet needs, and we have to hear their story, it shifts that stigma and helps them have some more empathy for that person with thoughts of suicide. So this was the past. These are preventable, that family pain. When we know there's loss in a family, it increases risk for the other family members. What we want to shift to from wrong care in the wrong place, with good crisis systems, it's anyone, anywhere, at any time can get the services they need. And Crisis Now is really helping us to build that. The core elements of the Crisis Now model are the high-tech crisis call center. It's like air traffic control. We're working tightly with Crisis Support Services of Nevada to build that level, where they have a program called Open Beds. Call in, they know where those open beds are so that they're not spending time waiting. They can get them to the place that's safest for them as quickly as possible. 24/7 mobile crisis, really important as well, so they can do the assessment and determine what level of care is needed. Many people with thoughts of suicide do not need that emergency department or inpatient care. And if we can get them the help they need at the most appropriate level they need, then those with acute crises can get in more quickly and safely and less dramatically. Crisis stabilization, we have the Mallory Center, and now, Reno Behavioral Health and Desert Parkway able to do this, which is fantastic. Instead of going to the emergency department, they go to a place that can de-escalate that crisis. Again, reducing that trauma. And we want to keep building those stabilization centers. Those that might not be able to be de-escalated will then be sent to that inpatient care that they need, but it's much more timely and safe. And then the essential principles and practices are really trauma-informed care, the zero suicide core tenets as well that we're going to talk about next. But I think you'll start to see these principles being built across our state and really probably impacting how those with suicide come through this with better recovery. kind of already broke that down for you. Sorry. I do this in a shorter presentation. We have incredible mobile crisis. I know with our youth mobile response, they have diverted youth and their families between 75 and 85% of the time. Rural mobile crisis really works hard to do face-to-face, but with the great distances in Nevada and sometimes the demand, that's not always possible. So they'll shift to telemedicine to make sure they're meeting people where they're at. But it can really help surround that family with support systems, not only making sure that young person gets the help they need if they're acute, but also it's family stabilization. That environment I talked about, those stressors that might be alleviated so that when the young person comes back, they're in a healthier place as an entire family. The crisis stabilization, as I mentioned, law enforcement often is the one working with someone in crisis, and in states like Arizona and Maricopa County, Colorado as well, the law enforcement knows that they can drop this person off. It's quick, and they don't turn them away for anyone. They have developed those stabilization centers that will accept anyone, as I mentioned, anytime, anywhere. And that empowers law enforcement to believe in the system, to feel safe helping that person with a mental health crisis. And it just reinforces the system of safety for everyone. The living room model, I think, is wonderful. It's a warm and welcoming facility where they really can de-escalate, often connecting with their own internal coping strategies to de-escalate, and then can be released to home with a safety plan and support systems. The principles I mentioned, recovery orientation, trauma-informed care, peer staff. What a better way to let someone know there's hope and help through a suicide attempt or suicide crisis than someone who has survived it with lived experience. And that it can be done and they can maintain recovery and safety. It's really, really powerful, and I know Nevada is building those peer supports as well in our communities. And collaboration, law enforcement, our mobile crisis often has a law enforcement officer and a mental health clinician that has worked really well, and we want to keep supporting those efforts. So now I'm going to turn it back over to Brandy for a really quick video on zero suicide.
Across the globe, it robs families of loved ones, young people of their future, workplaces of colleagues, and communities of their most valuable resource, their people. And surprisingly, of the 800,000 people a year worldwide who die of suicide, most saw a healthcare professional in the year prior to their death. Contrary to popular belief, the problem isn't that those at risk are disconnected from healthcare. It's that gaps exist that allow these individuals to slip through. Despite this, healthcare has remained unchanged, presuming many deaths were tragically inevitable. Inspired by the Henry Ford Health System in Detroit, zero suicide is a call to action based on the belief that no suicide is fated. It all starts with zero because a radical and systematic approach to prevention is the only way to create dramatic change, and it must be driven by leadership's commitment to creating a new culture around suicide prevention. 3 specific evidence-based interventions have emerged as central to zero suicide, creating the multi-layered approach that helps ensure no one slips through the cracks. First, we must make it okay to talk about suicide. Healthcare must routinely screen for suicide risk at all patient touchpoints within a health system. Simple screening questions like, do you have thoughts that you'd be better off dead or hurting yourself, allows healthcare professionals to start a conversation about suicide, create a connection, and acknowledge the anguish and pain. The simple act of asking about suicide risk is more predictive of a future suicide attempt than even cholesterol scores are for a future heart attack. Second, the strongest resource in preventing suicide is always the person at risk. By collaboratively designing safety crisis plans that include reducing access to lethal means and following up with phone calls after discharge, one recent study showed a 45% reduction in suicidal behavior. And third, we must treat suicide directly. We've assumed that treating mental health and/or addiction will fix suicide risk, but that doesn't always remedy the pain that underlie thoughts of suicide. Zero Suicide trains health professionals to deliver specific treatment as well as caring and supportive contacts, either between appointments or as post-care follow-up in the weeks and months to come. This relentless pursuit of perfection and insistence on evidence-based intervention works. Henry Ford saw a dramatic 80% reduction in suicide and maintained that success over a decade, including 1 year when they actually achieved zero. And at Nashville-based Centerstone, one of the largest nonprofit community mental health programs in the US, they reported a 64% reduction in suicide deaths since implementing these initiatives. And on the other side of the world, Gold Coast Health in Queensland has succeeded by utilizing the resources of the Suicide Prevention Resource Center, including a specific toolkit with a set of practices and resources for data collection and continuous quality improvement. Additionally, thousands of other organizations around the world are now taking their first steps towards zero suicide. Bold visions have put a man on the moon and cured polio. For suicide prevention, there's no more time for half measures and missed opportunities. Only with insightful leadership committed to the pursuit of zero suicide will we be able to make significant strides towards eradicating these tragedies. Zero suicide, healthcare that believes no one should die alone and in despair.
Thank you so much.
Every minute of every day.
It was that good. We're going to watch it one more time. All right, I just have to get my screen back. And then we'll wrap it up in the next 20 minutes and get you making sure you have some questions. Okay. So I really like that video in such a short amount of time. It shows the incredible successes that are happening around the world. These are the 7 elements they mentioned, and if this is something you want to bring to your community or facility, please don't hesitate to email me. Sherilyn Rarwood is fantastic and so committed to this. She is currently doing weekly sessions with engaged facilities and communities on breaking these 7 elements down. We had planned on a Zero Suicide Academy April 2nd. She had worked tirelessly to prepare it. We had about 100 people coming, and then you all know what happened. So instead of letting the facilities and communities kind of wait, we didn't want to lose that momentum. So she's been creating webinars and keeping people connected to developing their policies and procedures, to working with their workforces to build all of these 7 elements. So I'm going to go into these in a little bit of detail just so you see the tools that are available. Lead, we absolutely have to start with the hospital leadership or the system leadership. It is everyone in the facility becoming a part of suicide prevention. Everyone has a role to play. We feel that way with communities nationwide. Everyone has a role to play. It's just, what does that role look like for you? And leadership has to support developing a team in the facility, zero suicide team, to lead the charge. It takes IT work so that we know to screen and collect that data so we can surveil the system and also improve the efforts. So Sherilyn has meetings. That's the first thing she does, is meet with the CEOs, do presentations like this to make sure everyone's informed. Then training. We have a workforce survey that some of you might have seen, and it's meant to go to the entire hospital staff to find out what their attitudes are about suicide, what trainings they would have received, what trainings they utilize, if any, and what they need as a facility that they think would improve their suicide safer care. It does break it down into, it goes to everyone, and then it kind of breaks down toward you get to clinical, who has more experience with the suicide work. So it doesn't take everyone's time up a lot, but those working more directly with patients with thoughts of suicide will have a longer survey. And we find out where the gaps are. So some of the trainings are, as I mentioned, the 2-day assist, the 3-hour safe talk we find really valuable for physicians, nurses, and other staff. It's an alertness training that helps with stigma. And then that mental health first aid is an 8-hour training that can come in and give the skills for early intervention when a mental health crisis is just beginning, and for youth in youth mental health first aid, when mental health concerns are just starting. If we can connect youth and their families to help as the concerns are beginning, it really can prevent the derailment of their education, their relationships, their work, and get them on the right path to safety. Get them help they need so it doesn't exacerbate the mental health concerns. Identification. Again, through screening, I have several up here. The PHQ-9 is often used, 9 questions, with the last one being about suicide. But I think research has shown that that's more focused on depression and not necessarily addressing suicide risk sufficiently. So the Columbia Suicide Severity Rating Scale is an evidence-based screen, and they have assessments as well if you want that longer-term assessment. that are excellent in multiple languages. I would say 30 languages, and they work in different communities. It is open source. If you go to the Columbia Lighthouse Project, you can access any screens and assessments and the research behind it. We are having multiple trainings coming up with Columbia. They are so generous. They will come out to Nevada and support all the work we have. So I think Sherilyn's doing a training online with her facilities coming up in the next week or two. They have all ages for the Columbia as well. And ASQ is for youth. I think they go down to year 8 years old, 18. They've done incredible research out of Parkland, Texas, millions of screens and interventions, and they've broken down the myth that if you screen, it takes up a lot of time and diverts your workflow. Absolutely not. It's 4 questions. One of my favorites is, have you ever wished your family would be better off if you were dead or without you? I think that's a very telling question for young people. That burdensomeness again, and we can really intervene with that. What would it take for you not to feel like that? So very simple 4 question screen for young people, but safety is another one that's been around for a while. So these are all open source for you if this is something you want to bring, but there are probably others out there as well. This is an example of the Columbia. It has the yellow, orange, and red, and some of our communities like Carson City have developed the pathway to care depending on where the person screens with yellow, orange, red. So if they're red, one of the first things would be taken to Mallory Center. We hope to develop these kind of pathways for each community with the specific resources. We know if people trust in where to go and that pathway to care, they're more likely to feel confident screening. And then we will recognize those with risk much more readily. So it starts with, have you wished you were dead or did not want to wake up? Have you ever thought your family would be better off without you, down below? This is the ASQ I mentioned. In the past few weeks, have you wished you were dead? In the past few weeks, have you ever had thoughts of killing yourself? And then, have you ever thought your family would be better off if you were dead? I ask that when we do the signs of suicide screening. It just gives so much information. And it's amazingly common for our young people. Engage. If they have been assessed for risk of suicide, we want to make sure the pathway within the facility, a pathway for suicide care management, is developed. So that's an internal policy and practice that I'm not sure how often is being used in Nevada. It possibly is in several facilities, but we want to make sure that safety planning, that support planning, the connectedness, building up those connectednesses so that they believe in their care and treatment and have hope. The Psychiatric Advanced Directive is something I really like. It's not necessarily here in Engage, but I think anyone in care should be offered it. Like a medical advanced directive, it gives people a voice in their care. And the Psychiatric Advanced Directive came out in the 2017 session. And I don't know that too many people know about it, but when someone's well and not struggling with crisis, they can let you know who their support system is. If they were in crisis, who would they want called to pick them up or be a part of their safety planning? What facilities are therapeutic to them and safe? What medications don't help them? What medications do? So when they're well, they can get that out on paper, because often in crisis, the withdrawal, the blocking out of the support system, they are sent home and alone, and that's really not helping their safety and recovery. So I encourage people to utilize those if they can get out there. Safety planning, we hope to put on safety planning education videos on our Nevada Intervention Connection website, because this is so important. In the decades ago when I was on the hotline, the only safety that happened was a safety contract. You promise you won't kill yourself. You promise you won't do this. And the research has not bared out that that was effective. This is different. It has so much involved in it with what triggers you, what are your internal coping strategies, who are those people that keep you safe, who can you call, and it really pulls from your internal coping and external supports, ultimately with those hotline numbers and the clinician number if nothing else works. But these have been effective, and when we do follow-up on checking on how they're feeling, since we discharged you and you built this safety plan, have you had thoughts of suicide? If it's working and they aren't having thoughts of suicide, great. We're going to keep supporting them until they get into the next level of care they need. But if the thoughts of suicide reoccur, then we need to tweak the safety plan and find out what we've missed. So incredibly important upon any release or discharge. I mentioned the counseling and access to lethal means, so there's the website. It is really, really excellent and only 90 minutes. These are the brochures we developed in 2012 and 13 when we really became part of youth suicide is such a high concern for the Child Fatality Review Team. They helped fund lethal means safety for us. And it's in Spanish and English. We give some of these out at physician offices. Really important you can hand to the family. So not only the medications, firearms, and other dangerous things that might be in the house, but also what to look for, how to listen, who to turn to if you're concerned. This we give out at the gun shows, and it's really excellent for firearm households, firearm owners. I have heard, our family, our kids go through firearm safety courses. They know how to handle a gun, and my first thought is, well, if they're ever having thoughts of suicide or depression, that means the lethality increases. Really important to keep your family safe. If it's accessible, and we have had many losses in Northern Nevada linked to access to lethal means, that this is something we can do today in our households. There's the information on advanced directives, so you can find that and share that with your clients or families. Treat. As I mentioned, directly treating the thoughts of suicide is incredibly important. So not only is the collaborative assessment and management of suicide, it's excellent. It's online. That course you can take. Dr. David Jobs does a beautiful job working through that model. It's relatively affordable. We are bringing CAMS to Nevada down the road a bit with some of our zero suicide grant work. So if you are a clinician who is interested in CAMS, get a hold of me as well, and we can get you registered for that. Dialectical behavioral therapy for suicide, cognitive behavioral therapy focused on suicide, ACT, excellent treatments that have proven well with suicide specifically. Then the transition, discharging out into the community. They have this incredible program called Caring Contacts. As simple as a postcard quarterly can be life protective. It has been researched time and time again for decades. They are now moving into carrying contacts through texting. The VA here in Reno does this really well, so we're going to learn from their work. But it's a non-responsive method. We don't ask anything of the person we're sharing the card, sending the card to. It's purely just, we're thinking about you, hope you're well. If they've missed an appointment, this would be an opportunity to send one. We missed you at your appointment, hope you're okay. If not, here's a hotline number, here's a text line number. It's really that simple, letting them know they're not alone and people are thinking about them has proven time again life-saving. So we look to make these programs available through our zero suicide work as well. Some of the ideas, we're working with the social work department, associations, but we need that, we need the discharge planning process so that we can have contact information, and HIPAA sometimes can be a challenge for that. So if anyone has creative ways on how we can build this program, we welcome it. It would be a low-hanging fruit of effectiveness for suicide prevention. This is kind of the example. Thinking of you today. I'm so glad we met. I'm looking forward to seeing you next month. Simple as that. Then the follow-up and monitoring. We really want to make sure things are working. The safety plan's working. They made their appointment. If not, what happened? Were they having trouble getting into someone? Was it a financial or transportation issue? Now we know telemedicine can be incredibly helpful under these challenges. So we want to just double check and see how the support system's working, how their internal strategies are working. Are the triggers still there, or have they kind of taken care of them? And then that constantly improving the policies, procedures, and data. The EPIC, the databases can ask the screen right there and then flag if people have missed appointments. And so that means we can follow up. Really, really important. And Zero Suicide helps us do that. They have a checklist of technology needs that should be built as you're beginning your Zero Suicide implementation. Again, back to the resources. If you are worried about someone, I often tell people I know you're in high levels of work with mental health and suicide and substance use in this group, but sometimes trainings remind us of those we're around, our loved ones or friends or colleagues, or just right now, isolation is impacting so many people. Be it they have a job they love and they can't quite do it the way they want it, or they have a very difficult frontline job and they're just not getting self-care. If this reminds you of someone and you're worried about it, what a great day to say, hey, I had this training. I need to talk to you. It made me think of you. Also, I walk my talk, so I am more than willing to help intervene. If you're worried about someone, I can connect, get permission for me to reach out, or give them my cell phone number or email, and more than willing to reach out and see how they're doing. You also have the 24/7 hotline. That is an option, and excellent. This is a physician wellness coalition. They've been around for several years looking at burnout and physician suicide because we know it has touched our community. And Dr. Stephen Graybar has so graciously offered to be a part of this wellness line. He has colleagues that support him, and it's not 24 hours, but they will get back to you. To really build that safety, I know this is a difficult topic for healthcare providers, but if you're worried about someone or yourself, this is a safe way to get them help. Also, UCSD has a program for their school campus that really focuses on this, so you might find some great resources at that website I wanted to share. And then this is the new one. Dr. Ackerman asked what we had put in place with some of the funding. We started developing warm lines to support the crisis support services suicide prevention lifeline. We just didn't know what was going to come our way with diagnoses, with isolation. We didn't know if the hotline would be overwhelmed, so we started building supports. This is one with UNLV focused on the frontline healthcare providers. So it just opened this week. It is available to share with those frontline staff who have difficult decisions, who might be overwhelmed and not getting enough sleep, the stressors of this new circumstance. It's a great opportunity. And I know they were looking for psychiatrists, psychologists to help volunteer. So please share this for volunteers as well. These are some websites that can help answer any questions that I might have left unexplained, but I know we're down to the wire on the PowerPoint and open for questions, so we have plenty of time to bring up any questions. This is my staff throughout Nevada. Sadly, I have one staff member in Las Vegas with some of these grants we're waiting on. We hope to expand that. But they're an incredible bunch of people really dedicated to this cause. This path has chosen them, and I'm so grateful to have them on my team. So we have two trainers who in North and South, and we'll go out to the rurals if you need training for your staff. And on that note, I will get out of here, and maybe we can open up the camera. Lovely faces.
If you have any questions for Misty, you can put them in the chat box, or you can raise your hand and I will unmute you.
It's Friday, and I'm sure you're not opposed to ending a little early and beginning this beautiful weekend.
Misty, did you answer? I had Patrick asked, are you familiar with Walk the Talk America?
Oh, I am, Patrick. So with our governor's challenges and our mayor's challenges, I mentioned lethal means safety is a big part of our work. And so Walk the Talk America with Mike and, why did I just forget, our lovely Zephyr. Whiskershin. Sorry, that was really sad. It's my Friday brain. Jake, they presented to us and did such a beautiful job. I know they really want to get clinicians in the room with firearm culture, and they take you to a shooting range and let you kind of experience that. And then it's also how to talk about access to lethal means, and excellent program. So if you are interested in something like that, we can connect you. But Zephyr Wellness as well with will help you get connected to their trainings. They had some trainings recently planned, but then again, the pandemic, so I don't know where they're at with that.
All right.
Okay,
We also
now just,
how long is the mental health first aid training and the cost?
so mental health first aid training, it has shifted a bit. I think there's a 4-hour component you can do with self-study, and then a 4-hour face-to-face. I don't know where they stand with virtual. I don't think they're doing online full-on trainings, but they have shifted it to that 4-hour self-study with a lot of material. We have materials. I think the max it costs here in Nevada is $20, and that's just for the materials, the book. So for our youth mental health first aid, it's about 8 hours. Again, with that 4-hour shift, if you want to do the self-study, that would shift it a little bit.
Thank you. Any other questions?
I will put in my staff member, the trainer, her email if you want to look into training.
Okay, thank you.
If I can type properly. That's Jeanette Masolo.
I do not see any other questions. Thank you, Misty. I will go ahead and hand it over to Rima.
Great. Thank you, everyone, for your time. Take good care and be well.
Yes. Thank you, Misty, for sharing this presentation with us, and thank you all for joining us on today's call. Once you leave today's webinar, you will be receiving a survey on the presentation, and we would definitely appreciate if you would complete that and to provide your feedback. On behalf of the Nevada Primary Care Association, thank you for joining us today, and have a great rest of your day and have a great weekend. Bye.